Hi, everyone. Thank you for joining us today. I am Heather Augustyniak, the lead nurse practitioner for Baptist MD Anderson's Cancer Survivorship Program. Today, I'm happy to introduce to you Baptist MD Anderson's pelvic floor physical therapist, Jana Parnell. She graduated with her doctorate in physical therapy from the University of North Florida and went on to complete a postgraduate women's pelvic health residency. She's a board certified by the American Board of Physical Therapy Specialties. She's a Jacksonville native, and she has a passion for bringing pelvic floor health services to the First Coast. So please welcome me in introducing Jana Parnell.
Thanks, Heather. All right. Good afternoon, everybody. So we're going to be talking today about how cancer affects the pelvic floor muscles in men and women. And Heather already mentioned some of this, but I'm from Jacksonville. I went to UNF for my doctorate of physical therapy. And after PT school, I realized that I wanted to work in the pelvic floor region, and we don't get a lot of training with that in PT school. So I went on to do a post-grad residency, and I currently practice at MD Anderson 2 days a week, and then I'm in a primary care clinic the other 2 days a week. Some of the objectives for our discussion today: I'm going to hopefully describe the anatomy, physiology, and function of the pelvic floor muscles. And then I'm going to describe some common gynecological, genitourinary, and colorectal cancers. After that, we're going to talk about how these cancers are treated, either through radiation, chemo, or surgery. And then through that treatment, how those treatments affect the pelvic floor. And then hopefully you guys will get a lot out of this. And if you're experiencing any of these symptoms, hopefully you can get some help. So we're going to start by describing what the pelvic floor is. It's a compound structure which closes the bony pelvic outlet. That's just a fancy way of saying all the bones, fascia, and muscles down in your pelvic floor. It makes up the floor of our core. So if you think about your diaphragm being the roof of the house, your abdominal muscles being the wall of your house, and your low back muscles also being the wall of your house, your pelvic floor is the bottom of your house. And the function is to support those pelvic organs. And one of the things we're going to be talking about mostly today are those pelvic floor muscles. So this is a picture of the pelvic floor region in a female and a male. Yes, men have the same pelvic floor muscles that we do, but you can appreciate the structure on the right. You can see that men have a lot more structure to support their pelvic floor, which is why men don't have as much incontinence as women do. We have to have an open pelvic region because we have children. So that's why our area is a little bit wider than men's. Okay, so the pelvic floor muscles, I like to call them the hammock. And that's because they are responsible for keeping everything up. They're responsible for continence, sexual function, and supporting our low back and pelvic organs. So they run from the front to the back, just like a hammock would. So that's why I like to use that reference. And they're made up of 3 different layers. They run superficial to deep. That first layer is the superficial perineal structures, and it's several muscles. They're all listed here, and they're primarily responsible for sexual function. And when I'm assessing these muscles, you can see them with the naked eye, just kind of looking at someone's perineum. These are the 3 muscles that I focus on. And then I'm also looking right here where this orange circle is. When I'm assessing my patients, I'm asking them to see if they can contract those pelvic floor muscles. So if you've ever heard of a Kegel, I'm asking someone to try to squeeze those muscles like they're trying to stop the flow of urine. And I should see right where that orange circle is, contract up and in. A lot of people don't know how to do a Kegel. So if I'm asking them to contract and I'm not seeing any movement where that orange circle is, that means they probably aren't doing a good Kegel or a Kegel at all. I'm also asking for patients to relax their pelvic floor, because just like contraction is important, we also need to be able to relax these muscles, to have a bowel movement, to go to the bathroom for intimacy purposes. So I should see that orange circle come down if I ask them to bear down, like they're trying to have a bowel movement. If they don't do a good job of lengthening and relaxing those muscles, they're probably going to have difficulty having full bowel movements, pain with having bowel movements, or maybe pain with intimacy. The second layer we're not going to really talk about. It's just a bunch of fascia. And then the third layer of the pelvic floor is also known as the pelvic diaphragm. It's responsible for continence, organ support, and the closure of the pelvic floor. So the main muscles that I focus on when I'm assessing this layer of the pelvic floor are the levator ani muscles. They elevate the vagina and those pelvic organs. They provide a shelf for those organs to rest on, and then they help definitely with continence. But again, if these muscles don't do a good job of relaxing, you're going to have some issues. And we can see those muscles here. So now we're kind of looking down at the pelvic region from the top. When I do an internal assessment, I'm feeling these muscles to see if there's any tender points, pain, or any reproduction of their symptoms. If these muscles are overactive or are always clenched, a lot of patients will have reproduction of bladder pain. They might feel like they have a UTI, but they don't have a UTI. It's because these muscles are clenched all the time. And again, if we can't relax these muscles, you can imagine how going to the bathroom or being intimate with someone would be painful. If you don't do a good job of contracting and strengthening these muscles, that might make it difficult to stay continent. So you might have leakage of urine with laughing, coughing, sneezing if these muscles aren't strong. The pudendal nerve is the nerve that innervates this region. It comes from the sacral region of S2, S3, and S4. And you can appreciate where that structure runs. So if you're having issues at the pelvic floor or maybe some hip issues, that might cause some irritation to that pudendal nerve, which might make you feel like you have some nerve irritation in that perineum. Okay, so some common gynecological cancers: cervical, ovarian, uterine, vaginal, or vulvar cancers. I do see a lot of patients at MD Anderson that have had one or some of these cancers. And then some genitourinary cancers: bladder, kidney, prostate, testicular, and penile. Prostate being the one that I would see patients with the most because it does affect the pelvic floor region. And then colorectal cancer, so bowel cancer, colon cancer, rectal cancer, and then we know some of the risk factors that are listed there. I do see a lot of patients that at Baptist MD Anderson that have had one of these cancers. They might be experiencing constipation, fecal incontinence, or maybe even pain with intimacy because the rectum is so close to those other regions. Okay, so how do we treat these cancers? So oftentimes radiation is prescribed to patients that have one of the cancers that we just talked about. Radiation works by making small breaks in the DNA of the cancer cell, but can also affect cells of normal tissue in that area. That's the main thing that I'm going to be talking to you guys about today. As effective as these treatments are in killing the cancer, they don't do a good job of leaving our healthy tissue behind unaffected. So you can get internal radiation therapy or brachytherapy. It's where they insert a cuff into the vagina if you have one of those gynecological cancers that I was talking about. Also external beam radiation therapy. And so that's when that radiation is kind of beamed down onto that region that they're trying to target. And again, you can imagine it's going to kill the cancer, but it's probably going to affect all the cancer in that region, all the healthy cells in that region. So because of that, patients will often have symptoms and side effects of that radiation after they've finished and after the cancer is gone. That radiation can cause vaginal dryness, vaginal vault shortening. So the length of the vagina might become shorter, making it hard to have speculum exams in the future for surveillance, making it hard to be intimate with a partner. Oftentimes those patients will describe that they have pain with intercourse and it feels like there's a barrier or a wall there preventing them to be able to have intercourse. They might describe pain with pelvic exams. Some of the males might describe that after they urinate, they dribble or they leak urine. That's called post-void dribbling. Or males and females might describe urinary incontinence. So leaking with coughing, sneezing, laughing, or leaking with urgency because that radiation has made the bladder a little bit more sensitive. Or they can have a combination of both, which is called mixed incontinence. They may also describe fecal incontinence or urine and fecal incontinence, which is a double incontinence. And then my male patients might describe that they're having some erectile dysfunction because those pelvic floor muscles are not as strong as they used to be. And we need those pelvic floor muscles for a male to be able to achieve an erection. They might have pelvic pain, weakness in those glutes or hip muscles or those pelvic floor muscles, because again, that radiation is targeting the cancer, but it might be affecting those healthy muscles in the area. Constipation. So if someone has colorectal cancer and they get radiation, that radiation can cause tightening or fibrotic tissue to accumulate, making it difficult to have a full bowel movement. Skin changes might be blistering or redness to that region. And then, like I was saying earlier, that bladder can become inflamed. So that can cause you to have symptoms that are very similar to a UTI. So burning in the bladder, pain with urination, things like that. And then again, vaginal stenosis or vaginal narrowing. So we talked about the vaginal vault getting shorter, but the circumference of the vagina can narrow as well. Okay, so chemotherapy, another option for treatment in cancer. It's the use of drugs to destroy and prevent replication of cancer cells. It works throughout the body. So naturally, you can assume that although it does kill those cancer cells, it's going to affect healthy tissue throughout the body. It can be administered through an IV or via a pill. And then there's also hormone therapy. So sometimes cancer, it can thrive in an area that has a lot of hormones. And so if we want to kill that cancer, they're going to starve the body of those hormones to try to help kill the cancer. Some of the hormone therapy options are aromatase inhibitors, and it starves the tissue of estrogen, therefore starving that cancer of the estrogen that it needs to thrive. And then androgen deprivation therapy, which is going to be starving the body of some of those male sex hormones to hopefully help decrease the cancer or decrease the spread of that cancer. But you can imagine between the chemo and these hormone therapies, it's going to affect all the other tissues in our body with creating some of these issues listed here. So oftentimes patients will report that they have joint pain, vaginal dryness. Again, you can imagine if we don't have estrogen anymore, that's going to affect the vagina. So we know that those female hormones are responsible for keeping the vagina nice and moist, those pelvic floor muscles strong. And so if we get rid of that estrogen, a lot of my patients, even my younger patients that have had it, can describe vaginal dryness. It will accelerate that menopausal change. So hot flashes, vaginal dryness, vaginal atrophy. It can affect muscle strength and tensile strength of the ligaments. So not just the pelvic floor, you think about the glutes that are in that region, the hip muscles that are in that region. Weakness overall is a common complaint of patients that have had chemotherapy. It can cause pain with intercourse because of the vaginal dryness and everything else that I mentioned. Incontinence because of the muscle weakness. Decreased libido. So libido is multifactorial. If you don't have all the hormones that you used to have, your libido might decrease. Osteoporosis. So we might not worry about osteoporosis in someone until they're older, but being on these medications can, make our bones a little bit weaker. And so we have to worry about osteoporosis developing earlier than we might have expected it to. Erectile dysfunction. Again, that's multifactorial, but we know that if you have weak pelvic floor muscles, you might not be able to achieve that erection. And then again, it's going to weaken the bones like we talked about. Okay, some of the common surgeries that I see referrals for are the three listed here. So the first one is going to be a total laparoscopic or abdominal hysterectomy and bilateral salpingo-oophorectomy, which is basically a fancy way of saying they remove your uterus and your ovaries. They might leave ovaries, but just having abdominal or laparoscopic surgery to that region, they have to cut into those abdominal or pelvic floor muscles. And so anytime a muscle is being cut into, even if it's a very small amount with the laparoscopic, those muscles can be affected and can be weak. Scar tissue can accumulate, which can be very painful. Radical prostatectomy. So in a patient that's had prostate cancer, they're going to remove the prostate, but again, cutting into those pelvic floor muscles. I would say most of my patients that have had a radical prostatectomy do develop urinary incontinence. So this is something that you might want to see a physical therapist for, so they can help you re-strengthen and retrain those pelvic floor muscles after that surgery. And then colon resections. So some of my patients that have had bowel cancers or rectal cancers, anal cancers, they might develop fecal incontinence because those muscles are not as strong, and they've also lost part of their bowels. So that stool isn't as formed as it used to be, which makes it harder to control. And so getting in with a pelvic floor physical therapist can be very helpful to help really strengthen the pelvic floor muscles that are still there to kind of counteract what's happening with that looser stool. Symptoms and side effects of surgery of the pelvic floor. So pain, just surgery in general can cause pain. Some of that scar tissue can cause the pain as well that I was talking about. So after you've had surgery, if you feel like everything's tight and you still have scar tissue left behind, that doesn't just go away typically. So really getting in with someone to help break up that scar tissue. And we know that scar tissue affects the muscle's ability to contract. So you won't get as good of a contraction of your muscles if there's a lot of scar tissue left behind. Abdominal pain, constipation, incontinence, for all the reasons that we just talked about. Those muscles are not as weak, or maybe you have a lot of scar tissue, which is affecting your ability to have a full bowel movement. So you have some constipation. Okay, so this is what I do to help all these patients if they have any of these side effects after cancer treatment. I spend a lot of time educating my patients. I would say half of what I do, if not more, is education, talking to people about what they're doing outside of physical therapy that might be exacerbating their symptoms. And we'll get into that a little bit later. I do manual therapy, so massaging, helping to break up scar tissue, helping to relax pelvic floor muscles can be really helpful in that manual therapy aspect. Exercising to help strengthen and contract those pelvic floor muscles, to help strengthen those abdominal muscles and those glute muscles, and then neuromuscular re-education. We'll get into this in a little bit later, but a lot of people don't know if they're doing a Kegel correctly. They don't know how to contract those pelvic floor muscles because they can't see them. And so we have to spend time on getting patients to realize that there's a mind to pelvic floor connection and how to strengthen that connection so that they can do a Kegel. Okay. So going back to what I was saying earlier, about half of what I do, if not more, is education and behavioral modifications. I spend a lot of time talking to patients about the things listed here. So women that have had vaginal cancers, GYN cancers that have had radiation to that pelvic region, or even women that have had colorectal cancers that have had to have radiation, they can get that vaginal vault shortening or that vaginal stenosis. And that's not going to go away. It's probably only going to get worse. And so educating them on how to use dilators. That's that first picture here on the left. Dilators help stretch and lengthen that tissue in a slow way so that it's not painful. I teach patients how to use these dilators. I help fit them for the right size to start with, to build up to their partner size. If sex is not a goal, if intimacy is not a goal, if someone's not interested in that, we do build them up to a size that's appropriate for them to still be able to have those speculum exams, because we do know that they're going to be getting speculum pelvic exams in the future for cancer surveillance. So that's what I use dilators for. I teach patients about constipation management, learning how to sit on the toilet properly, learning how to rub their belly to help facilitate better bowel movements. I talk to patients about, what are you drinking? If you're having bladder pain, if you're having urgency, if you feel like you're going to the bathroom all the time, what are you drinking? Are you drinking 7 Diet Cokes a day? If you are, I talk to you about hydration and maybe eliminating some of those bladder irritants. If patients are having difficulty holding their bladder, if they're going to the bathroom every 30 minutes, if they feel like they're going to the bathroom more than they ever have, if they're getting up at night a lot to go to the bathroom, I'll oftentimes put patients on a timed voiding schedule to help them retrain their bladder sensitivity so that they don't go to the bathroom 20 times a day. I'm teaching patients about how to suppress that urge to go to the bathroom. And then if they're having pain with intercourse, there's different positions that we can practice in physical therapy so that they don't have as much pain with intercourse. Some of the tools besides the dilators that I use are the O-nut, which is this middle bottom picture here. It's a way for when patients are having pain with deeper penetration during intercourse, it's kind of a barrier that I can teach patients how to use on their partner to prevent that pain with deeper penetration. And then this picture on the right here is a TheraWand. So if patients are having pain or tenderness to any of those deeper pelvic floor muscles that I would normally massage and do manual therapy on, this is a tool that they can use in the home on themselves to massage and break up some of that muscle tightness and scar tissue. Okay, so this is some of the manual therapy that I do. Some of those deeper pelvic floor muscles, one of your hip muscles, I can actually access vaginally. It's called your obturator internus. This is oftentimes very painful on women that are having pain with intercourse. And so I can release that muscle by doing a manual therapy technique internally. Doing massage of those pelvic floor muscles internally or externally if needed. A lot of skin rolling to the abdomen if you have scar tissue from surgeries or if you have abdominal tightness. And then teaching patients how to belly breathe. So using that diaphragm, are they breathing into their chest or are they taking that air all the way down into their belly to help release the abdominal tightness? And then as you'll see in this picture here, this is just some skin rolling. I can do that at the opening of the vagina if they have scars from childbirth, if they have scars from that radiation. Some of the exercises that I prescribe are oftentimes in the goal of lengthening and shortening the pelvic floor, which will help increase the blood flow to that region, which might help decrease pain. But also helps patients learn where their pelvic floor muscles are because they can feel those muscles moving during these exercises. These exercises are also given to help strengthen the pelvic floor. So the famous one is the Kegel, which I've been referencing. So a lot of times patients don't even know how to do a Kegel. And there's some research to show that if you just verbally cue a person to do a Kegel and you don't actually show them, 50% of people do it incorrectly. I'll find that a lot of patients think that they're contracting and squeezing those pelvic floor muscles, but they're actually bearing down and pushing those muscles out, which might exacerbate incontinence or pelvic organ prolapse. So we spend a lot of time when they come to see me for physical therapy on learning how to do a Kegel. And then from there, I might incorporate that Kegel into a bridge, which is this second picture here. We talked about that diaphragmatic breathing. So really making sure that when they breathe, they're taking that air all the way down. And then this top picture on the right here is cat-cow. So that's lengthening and shortening the pelvic floor, which all of these can be helpful with relaxation of the pelvic floor, but also strengthening the pelvic floor. So what do you do if you don't know how to do a Kegel? And I've tried to verbally cue them and I've tried to teach someone how to do a Kegel and I just really can't get them to learn how to contract those pelvic floor muscles. So there's something called biofeedback. I can insert a probe into the vagina or the rectum, depending on where the patient is having issues. And then I can hook that probe up to a machine. And once they squeeze those pelvic floor muscles, the machine will show that through a bar graph that the resting tone is increasing, meaning they've contracted those pelvic floor muscles. So it provides that visual cue to patients that they know, oh, look, I just contracted. I can see this bar graph going up. therefore, when they relax, that bar graph should go down. So it really helps patients see what's happening at that pelvic floor without actually being able to see those muscles, which can be really helpful. And again, this biofeedback can be used for up training those muscles, so strengthening and contracting those muscles, but also relaxation. So if I use the probe and we find that at rest, these patients are already in a clenched state, I can help them learn to relax those muscles. And that is all I have right now.
Thank you, Jana. A couple of questions came through the feed and wanted to ask you about them. One is, where can someone purchase some of the devices that you were talking about? And is that something they can purchase without a pelvic floor therapist, or do you recommend getting a referral to someone like yourself?
Yeah, so the ONUT product and the TheraWands and all of that, and the dilators specifically, and the squatty potty, so getting your feet up to have that good bowel movement, can all be purchased at Baptist MD Anderson on the second floor in the Life Wellness Center. But as far as knowing what dilator to start with, or knowing how to use that TheraWand to massage those internal muscles, I do think it would be beneficial in coming to see me at Baptist MD Anderson as the pelvic floor physical therapist. Heather is our survivorship nurse practitioner, and so she does refer a lot of patients to me that need training on using those dilators and making sure that we're progressing them. A lot of patients don't know, when do I go up to the next size? And so spending some time talking to patients about stuff like that can be really helpful. I wouldn't want someone to use them and not know how to use them, how long to use them, what size to start with. So even if it means coming to see Heather or me for 1 or 2 sessions, it can be really helpful.
Another question was from a colorectal female cancer patient that has had pelvic radiation and wants to know if any of this dilator therapy is applicable to her because she's had radiation in that area, but not for a gynecologic cancer.
Yeah, so oftentimes, like I was saying earlier, because the radiation does such a good job of killing the cancer, but it does affect all the other healthy tissue in that area. The rectum and the vagina are very close together. So even if you've only had radiation therapy to the rectum, you can still get that vaginal vault shortening, that vaginal stenosis. I've seen several patients that had colorectal cancers, but they were coming to see me because they could no longer have intercourse with their partner because of that vaginal stenosis, vaginal vault shortening. Also, it can affect how much your bowels open. So I have a patient that I'm seeing right now who is unable to get colonoscopies. And so keeping that area open as well is important for bowel movements and for colonoscopies.
Perfect. And I think last question of the day, excuse me, if the patients have had chronic issues before cancer, is pelvic floor therapy still a good idea for them as well?
Yeah. Oftentimes my patients have told me that they have pain with intercourse now after cancer, but they had pain their whole life with intercourse and they never knew what to do about it. They thought it was just something that they were going to have to deal with. And so whether you had cancer 20 years ago, whether you haven't had cancer and you're having pain with any of the things I discussed, it's definitely helpful to go see a pelvic floor physical therapist. It's never too late. We can always work on something, even if you've been dealing with something for years chronically, or even if you've not had cancer, or maybe you had breast cancer, but you're on some of these drugs that I mentioned and you're having vaginal dryness or pain with intercourse. It can be really helpful to still come see me as a pelvic floor physical therapist.
Well, thank you, Jana. Hopefully our patients got a lot out of today. I know I did. And just thank you for volunteering your time.
Thank you guys. Thanks for listening.
Take care. Bye.